Well, welcome everybody, and thanks very much for joining us to this hour-long webinar where Paul, our superstar doctor of Clean Slate fame, will be talking us through the drugs that we use to help people with alcohol and substance dependence. More formally, evidence-based pharmacotherapy for substance use disorder. And I'll just start with an acknowledgement of country by acknowledging the traditional custodians of the land and waters on which we live and work, and pay our respects to elders past, present, and future, for they carry the cultural wisdom, the stories, the traditions, and dreaming. With a commitment to reconciliation, we acknowledge the ongoing impact of past policies and practices and commit our endeavors to creating a just society and sector that celebrates the ongoing resilience and self-determination of our First Peoples and communities. So today's presenter will be the wonderful Paul Grinzi, who you probably already know as a very well-known medical educator, and myself as the medical officer of Clean Slate Clinic. I'll mainly be looking after the chat function and the Q&A. So yeah, if you have any questions as we go, please pop them in the chat. And yeah, if you have any resources or anything else you want to share, pop them in the chat function. Great.
Thanks, Chris. And yeah, I'm looking forward to sharing with you and everyone who's participating and also watching after with the recording our discussion, and looking forward to seeing what questions pop up. And as Chris just said, if you've got questions, put them in the Q&A part. If you've got a comment or a resource or something that's not a question, chuck it in the chat part, and that way we can share our own knowledge that you're bringing along to the table as well. So I want to start off with, because this is an hour on drugs, on medications, and I want to start off with really just framing this, because I think sometimes with these talks, which are very popular in terms of topics, we forget medication's place. And for me, when we're talking about substance uses, it's sort of in this hierarchy. It can be important, and it's important tonight because it's the topic of tonight, but really medications by themselves don't do much. They have an important role, but without looking at the whole person within the spectrum of their social milieu and the community, which is where substance use really sort of has its tentacles, but also it has its protective factors, its recovery capital as well. If we're missing all that and we're focusing on just what we can prescribe, I think we're all going to do a disservice. So it's really a matter of looking at medications in the context, and then I'll keep reminding ourselves about the broader context. So I'm certainly not discounting things like the role of psychological process, physical assessment, and addressing those issues, and looking at the broader social aspects as well. But we will focus tonight on pharmacotherapy itself. So looking at substance use and the medications, I'm going to look at three main categories tonight, and focusing more on alcohol, because there's probably more pharmacotherapy involved with alcohol dependence than other substances. And then towards the end, we'll touch on other substances, how they may differ, or how they are similar to alcohol in that regard. So the three key areas we're looking at here is basically looking at medications around withdrawal. So we'll discuss withdrawal and what the purpose of the medications there may be. Looking at complications of alcohol use and how some of the medications we can use to help prevent complications. And the third category here is craving reduction medications. And I'll mention it now because I might forget later on. I talked about craving reduction medications, especially with my patients, rather than anti-craving medications, because they still got cravings, but we can reduce them. And sometimes they feel like if it's an anti-craving medication, any craving that comes through is a failure of the medication. It's not. It's just the nature of being human, I suppose, to some extent. We'll talk about that later on.
So some of my patients say sorry, Paul. Yeah, when I talk about craving reduction medications, they'll say I don't get cravings. I don't get a craving to drink, and then I sort of turn the conversation a little bit to the urge or the desire or the thoughts about drinking. Yeah. So sometimes the word craving can have different meanings for people.
Yeah. So we'll look at each of these, sort of the who's involved, the what's involved, when these various parts of the journey occur, and then also how to manage these themselves. So let's start off with the big one, in terms of big, because actually, I'll frame it in how I talk to patients. Often when they're seeing me, I congratulate them very early on. And they look a bit bemused because I've hardly met them. I've introduced myself and said a few hellos and niceties, and I say, congratulations. And for me, it's, longer term recovery is 3 phases, and they've just completed phase 1, which is actually accessing help. And that's probably the hardest one. A lot of people don't get to this point where they're actually accessing help. So I know there's the emotional roller coaster of people getting through. Don't I have a problem? Shouldn't I get help? How do I do that? Canceling appointments, coming back, and finally getting to this point where they're seeing me. That's a huge success, and acknowledging that, a real affirmation of type of approach can be really both nice grounding of where we've already come. And I know my point has just started, but for the patient's journey, it's along the way. And then I talk about 2 other phases. With alcohol, it's often a withdrawal, and that's fast and furious in terms of, well, I hope not furious, but only about a week or so, and we'll talk about that shortly. But the longer, phase 3 is where most of, I suppose, the real work, and that's maintaining and learning lifelong. And that's for all of us as clinicians, as well as clients and patients, learning about alcohol or other substances and how to adapt around societal's convolutions that have contributed to the substance coming into someone's life. So for me, the withdrawals phase 2 of a longer term process, and it's important to have a good process around this, although in the big scheme of things, it's a very short one. So in terms of alcohol itself and the withdrawal, most of the time people will withdraw within the first day of stopping drinking. Although some heavy drinkers do actually have withdrawal while they're still drinking. Their relative blood levels have dropped, and that leads to withdrawal. That's not that common, but that's a very much more serious situation at that stage. But for the most people that I see in the community, and they'll tell you when they start to feel a bit trembly. Often it's sort of almost 24 hours after they've ceased drinking, or a bit later. The most common thing would be people drinking in the evenings after work. And having a very heavy night and being able to sort of sober up for the morning, get some functional, and then start again. And if they don't have that drink, if they're delayed for some reason, within a few hours of that normal time, that's when they start to withdraw. But some withdraw earlier and need to either drink earlier or adapt to the withdrawal symptoms at that stage. Now, the withdrawal syndrome usually only lasts, I suppose, occasionally it might go longer than a week, but the vast majority are done and dusted. The actual withdrawal itself, this phase 2, as I described it, within a week. Some are quite short and sharp, and so often they'll describe that the last few days are pretty boring. Nothing much happened, which suggests to me that the withdrawal was finished. But I often warn patients it's probably going to be 5 to 7 days, and then if it's a bit shorter, it's a bonus. If it's a bit longer, then we can work with that itself. The severe symptoms that we need to be worrying about, I'll talk about shortly. But in terms of what I ask the patients, what they know about withdrawal, often they'll know a few things. They've experienced things like maybe some shaking, or maybe some of the psychological things, anxiety, poor concentration, some sleep. But I go through these things so they're familiar with what they look like, because one of the things we're going to be doing is incorporating a new medication into the picture. And if they start to getting diarrhea, they may malattribute their withdrawal symptom with a side effect of their medication. So it's important to be aware of what the withdrawal syndrome looks like. So these are what we'd expect, and we're trying to mitigate this with our medications. The symptoms that would suggest to me that this is a severe symptom, they're complications, they're quite dangerous. Seizures, hallucinations, or other perceptual disturbances, or delirium. They're the 3 things for me are quite dangerous. And if someone's got a history of those things, then for me, they're not safe to do in the community, and they need sort of a more supervised setting like things. Now, I know, Chris, you work in outpatient as well as a community setting. How much of the sort of severe stuff have you seen people having withdrawal seizures or hallucinations or delirium?
We don't tend to have people have seizures when they've been an elective admission. So if we can catch people with the benzos, with the diazepam early, then we can prevent most seizures. But we do have a lot of people coming in through the emergency department who've tried to self-cease and they've had seizures, and then they come through to us at the Gorman unit. An interesting guy came to us electively only a few weeks ago, and when he arrived, he was in florid withdrawals, sweating. I mean, all of those things he had. Yet he blew 0.17 on the breathalyzer. So this guy was intoxicated yet in florid withdrawals. I mean, that's really unusual, and he ended up in intensive care. Yeah. So if you can catch people soon enough, if you can plan the detox, you can prevent pretty much all of the significant, the serious complications.
I've only witnessed one withdrawal seizure in my career, and that was as a registrar. Had a patient who came in only having drunk a quarter of a bottle of vodka that morning, which obviously wasn't enough, and he'd had a withdrawal seizure because that wasn't enough he'd run out of money and couldn't access anymore. So a quarter of a bottle of vodka for most of us by morning, mid morning, would be out cold type of thing. For him, he was in withdrawal. So that just taught me how much people can drink and be tolerant to, and then at risk if they can't manage that level itself. So, I mean, thankfully for me, it's a one-off, but certainly, as you're just saying, people who are heavy drinkers trying to cut down, so they're motivated to stop, we need to make sure that they're safe. And that can actually be one of the few times as a GP, I tell people, keep drinking, please, until we plan this properly to make it safe. Please don't stop abruptly by yourself, because it can be dangerous to do so. And we, some harm minimization around that, so we can time it properly. Now, one of the things that I'll be talking about medications and what we're going to be using around withdrawal, but one of the things we'd like to look at is why withdrawal actually happens. So, biochemically, when you're drinking a lot, there are neurotransmitter adaptations, and I won't go into the various ones, but if you're interested, they're basically GABA or NMDA receptor changes, mainly. So the body or the brain adapts to those, and then when you stop, that adaptation hasn't had a chance to readapt without alcohol, and everything's basically activated physiologically and psychologically. The way I describe it to the patients, I don't use any of that terminology. I say you're driving your car, and alcohol being a depressant, it's a bit like having your brakes on the car the whole time. So you're driving with the brakes on, and because you've been adapting to alcohol, you've got a little bit of accelerator happening all the time. So your car's pretty much sort of semi-functional with the alcohol compared to when you first started drinking. And when you stop drinking, the brakes come off all of a sudden, but the accelerator is still going for a few days before it realizes that it doesn't need to be accelerating. And so your brain and your body is accelerating. That leads to those symptoms like tremor and sweating and fast heart rate and the anxiety, and everything's activated. It only lasts about 3 to 5 days before it really settles down. But in the meantime, you're at risk of these very distressing symptoms or potentially dangerous symptoms. So that's how I describe it, using a car analogy. Most people get cars. Not everyone gets that. And so somebody's got to be more creative. But I think certainly steering away from the jargon of talking about neurotransmitters and how your brain works. No one knows how their brain works, let alone people who have got less medical training. Literally no one knows how the brain works. All right. So who's at risk of withdrawals? Well, really, anyone who's drinking regularly enough. So if they're binge drinking, so just Friday nights having a really, a disaster, they can still have alcohol use disorder or alcohol dependence, but they may not have the physiological adaptation because they're having a lot of alcohol-free days in a row on a regular basis that doesn't allow for that. So they may not go through withdrawal, although occasionally you see people who in that pattern who do, but it's more the regular drinking. And the level doesn't make a difference. It does make a difference. The more you're drinking, the more likely you're going to have a more severe withdrawal or have a withdrawal. But it's not protective. Having a few drinks, people can still have a withdrawal if they're having a few drinks regularly. It may not be as severe, and they may just feel have a restless sleep and feel a bit queasy in the morning. That they're attributed to a hangover rather than the withdrawal nausea. So the severity does vary, and the features that are on this slide here suggest with the history of where patients are more likely to have a bit more trouble around this. The biggest the best predictor really is that any previous withdrawal, whether it was intended or formalized or informal, asking them when they last had alcohol-free day and then an alcohol-free period, or any actual withdrawals, detoxes, that'll give you an idea of what this one's likely to be. That's probably the best predictor we've got out of all the factors around that. Is there anything else, Chris, that you add in terms of assessing our patients before we go into a withdrawal itself, in terms of, or advising them? Any education, extra things do you do?
I mean, yeah, you're absolutely right. So the only definite way of predicting if someone's going to have a seizure or the DTs is if they've had them before. Otherwise, it's really hard to predict. So if someone is drinking the large amounts and perhaps not eating or looking after themselves in other ways, then we can ask them to slowly reduce the amount that they're drinking. Maybe introduce an extra meal a day. Certainly start taking thiamine, which I know you'll talk about. So we can start to lower the risk before we do a detox, but by implementing those sorts of supports beforehand.
Mm. And so you mentioned a point that apart from the previous history, there's not a lot that you can really hang your hat to be really certain. And so this is where the role of pharmacotherapy comes in, because the pharmacotherapy we're going to be using, the benzodiazepine, is both has a dual role. One is to mitigate the severity of the symptoms so people can actually get through the withdrawal more comfortably. And more importantly, from my point of view, is a safety thing. They're less likely to have a seizure or those complications, delirium or hallucinations, if they're on, they've got benzos on board as well. Because it's basically, as I say to patients, your brakes have come off, the alcohol stopped. So we're providing some artificial brakes in the meantime while your body and your brain are adapting. While the accelerator's coming off, got some artificial brakes just to help control things and especially in those particularly the first 3 days. So diazepam is our benzo of choice, and that's all I'm going to refer to today. There are some circumstances where you may choose other ones, but for me, for most of us in the community, as a GP, I'm focusing on what works for the majority, and then I'll seek specialist advice if I feel like someone may not metabolize diazepam, or they're already on a regular regime of diazepam. What do I do now? That's where I get some advice. So that's what I'd recommend you do. And all our states and territories have got drug and alcohol clinical advisory services that you can call. So that they're quite responsive and very helpful for these sort of questions if you've got a particular situation itself. Now, there are different dosing regimes you'll read about. Now, towards the end of this webinar, we'll give you an Uber reference that covers all of this in even more detail if you're interested in looking at this further. And I'll describe these briefly. So symptom triggered requires an assessment of some sort. Usually it's a nurse assessment of various physiological parameters as well as symptomatic parameters, making a score, and then assessing, it's like a sliding scale. If they've got low symptoms, they have low dose. If they've got high symptoms, they have high dose. And so the dose is very flexible, but requires an assessment, and a patient only assessment can go awry. Because if you're distressed with higher symptoms, particularly the anxiety, you will miss dose because you're extra anxious, you'll have an extra one and it go over the place. Or if you're overdosed and you're a bit sedated, you won't think clearly and you may forget you had a dose and have another one. And so patient controlled symptom-based triggered schedules can be a bit problematic in that regard. There's also another regime called a loading dose, and this is more for the very severe, very risky, so heavy drinkers, those with previous complications, more of an inpatient thing where there's a really high first day dosing, almost to an endpoint of sedation or an absolute maximum dose, and then tapering down from there. I don't feel that's very appropriate for the community, particularly because that high dose, it's not supported, it's not supervised. It can be dangerous without just putting that in place. So to some extent, the one we've got left over, which is the one we do most commonly, is I do as a GP, sort of a fixed schedule. And that allows some certainty and some protection around that, but we've also pre-assessed our patients of being low risk of those complications, so they're unlikely to need those themselves. But importantly, it's the review. So whatever regime you decide, the reviewing is so important. It's not set and forget for that week. It's set and review and adjust and review and adjust if you need to. And it may be well that your fixed schedule works nicely, but sometimes you've actually got to pull back doses because people are getting quite sedated, they're quite sensitive to diazepam, and others need extra doses in because the dose we picked at the start just wasn't quite enough to cover the symptoms that they need. I always say to patients, we're trying to reduce the symptoms, not stop them altogether. Ideally, in the perfect world, we get the dose right, they don't have any symptoms. Now, I don't live in that perfect world. No, I aspire to get there, but we're aiming to make it more comfortable. So rather than no sleep, maybe some interrupted sleep. Instead of vomiting and diarrhea, maybe some nausea, but they can tolerate small meals. Just trying to reduce the symptoms so they can get by day by day. And if they can get by the first, the second, the third day, then they're much more likely to be able to complete the whole thing. So those first 3 days are really important. That's where that clinical review comes in. Chris, how often have you planned to review? Do you review patients daily? Is it every second day? Is it as needed for that week? I know Clean Slate, we've got a nurse review every day, so that's the advantage of Clean Slate's program. But not all of us as a GP will have the ability to have a nurse available every day. As a GP, what would you do in terms of review?
Again, it would depend on the risk, but my general practice was to review every day for the first at least 3 days, and that was for many reasons. You've covered some, but if I'm prescribing someone diazepam, I want to do that on a daily basis just to make sure that they're not drinking, they're not driving, I'm not over sedating them or under sedating them. So it's sort of to cover myself and make sure that the patient's doing okay. And things do crop up. People do have all the other things that happen in life during a detox week as well. So it's nice to be there for them for those things and give them that sort of hand-holding support through what is a difficult experience for them.
Yeah, I can't do that. I work part-time clinically. So for
Yeah.
me, it's making sure there's a support person who can be my eyes and ears to some extent and report back. And also having the ability of the days that I'm not working for a colleague or one of my clinic nurses to be available for a phone call, and they can contact me out of session if needed. So I'm still available even though I'm not physically reviewing them. And then what I've learned also is that telehealth works just as well. It's rare for me to have to see patients physically. It's often nicer, but we had, through lockdown, lots of opportunities to learn about telehealth and realise that actually the physical examination part is a very small component. The physical contact is probably a bigger, that relationship building and the rapport is probably a bigger contact. So the video is helpful for that. Phone's really challenging. But for most of this, there's actually very small physical things you need to be looking at. So a lot of it can be done remotely, which is what we do through Clean Slate, because we do have a telehealth program.
I guess it's an important point. We can't be there for our patients 24/7. So I'd always make sure that they've got a phone number to call if it's after 5 o'clock and my surgery will be closed, or if it's the middle of the night and they're struggling with cravings. And certainly in New South Wales, and I think in most states, they've got an ADIS, an alcohol and drug information service, which is 24/7. And staffed by counsellors who can help in that crisis moment.
Yeah, pretty much. As I said, every state and territory's got a clinical advisory service as well as a patient-facing information and counselling service. So we're lucky. I know addiction services around the state, around the country, are variable in terms of accessing physically, a specialist referral. But from a phone support, we're actually quite lucky in a clinical area that it's well supported in that regard. And I'm going to throw up an example of a fixed dosing schedule. And again, if this was my dosing schedule, I'd be reviewing and adjusting as accordingly, depending on how patients are going with this. It's only an example. So I know sometimes when I present similar things, there's a feverish of writing exact doses down, and that's fine to do. But sometimes you will actually have to adjust and go a bit longer, a bit shorter, higher doses. You may want to change it up. But the example we've got here is someone who's, I suppose, moderately dependent, not crazy drinking, 2 bottles of spirits a day, but also expecting to have a reasonably rough withdrawal without medication support. So the pharmacotherapy here is actually quite simple. It's just diazepam in a way that mimics the duration of the severity of the withdrawal. So it's all done and dusted within a week, and the first 3 days, particularly the first day and 2, are the ones that are most likely to be the most problematic for the patients. So the diazepam is there mimicking that ride all the way through, and it's tapered off. One thing I do see sometimes, which I think is a mistake, is some prescribers are prescribing diazepam to help people get off before they actually stop. So I'll give you some diazepam to help you taper down or help you stop, and it doesn't work. And all you're doing there is adding diazepam to alcohol. So it ends up being a much more, potentially a more dangerous or more problematic combination. So it's really, it's there for when someone has stopped. So day 1 of stopping drinking, it's a planned day 1, and then you prescribe for that week from there, not up to and approaching a sort of a nebulous quitting date. There is a bit more pharmacotherapy available to with withdrawal, and that's more about symptomatic management. Diazepam does a pretty good job for most of them, but some of these symptoms diazepam doesn't cut as well. So you can use what are fairly simple medications, but they can be quite important, and consider those for patients to consider. I've written a couple of the medications that have been used and either have no evidence or have too much of a safety profile consideration to be something that we would be proposing from symptomatic means. So certainly trying to avoid that bottom line. But certainly I'd be commonly prescribing or advising patients around using paracetamol or ibuprofen if they haven't had gastritis. Nausea can be common for some, and some don't have it at all. The diarrhea, managing it like other diarrhea itself. So there's nothing too complicated there, but just think about other symptoms, what's going on there. You'll notice that I haven't put so much things about sleep, like adding melatonin to the mix or adding other benzos, diazepam. Diazepam is our treatment here, and it's also the advice, the setting up education that the sleep has to adjust. You're going from what I call alcohol unconsciousness to sleep, because alcohol doesn't create our sleep waves and our deep sleep refreshing parts. It just makes us unconscious for a bit. And so our body and brain has to adjust, and so the melatonin has to kick back in, and we've got to give that a chance. It's really, the education is really important there, rather than focusing on pharmacology for every single symptom.
My dad used to say there's a difference, son, between going to bed and going to sleep and waking up and passing out and coming to.
I like that. I'll move on to the next topic, but keep the Q&A coming, and Chris will answer those there. And again, if there's anything particular for those who are listening to the recording that can't see the Q&A, if you want to bring those questions up, feel free to do so. I can't see the Q&A, so you're the boss in that regard. If there's small little bits, you can cover those. But was there anything that's worth sharing with the broader group?
They're coming through really, really nicely, actually, and you've been answering them as you've gone anyway. Certainly one person was someone called Anonymous Attendee, which is a very interesting name.
Very unique.
Saying if does somebody have to stop alcohol completely before starting the diazepam, and then which you answered, and then that makes it difficult for people to prescribe diazepam, because how do they know whether they're drinking or not? And certainly for my practice, we bought a breathalyzer. I think it cost about $200, but it worked for a good sort of 4 or 5 years. At Clean Slate, we do post out pocket breathalyzers, but that it's not essential to have a breathalyzer if you're seeing somebody face to face. You can ask them if they've had a drink and explain about the warnings. You're just giving them a small amount of diazepam to get them through that day before you can review them again the next day. But I think the breathalyzer is a nice thing to have to reassure you of that, and it's quite the pocket breathalyzers are quite handy for the patients to see how alcohol is affecting them pre-detox, and it's nice to get that positive feedback and see the zero when you blow in.
Absolutely. And the other way around, it's also interesting for people to learn how much alcohol is still in their system in the morning after a big night.
Yeah.
They may feel like they
Scary
realize,
sometimes.
so there's an education. Now that I've got access to breathalyzers, I've found them more useful, particularly not so much, I don't find them as useful in my clinic, but when patients have got them in their home and they can learn from it and get that sort of reward feedback loop happening, that can be really helpful as well. I'll move on because we've got an hour to cover through a few things, but we can always answer further questions as they come through. And I'm going to go through what's thankfully something we don't often see, but I want to give you a couple of providers around that initial thing. And this is complication. It's not a complication of withdrawal. Wernicke-Korsakoff syndrome is related to alcohol. And there's an opportunity around withdrawal to address this because patients are often treatment seeking and involved with us. But anyone who's drinking, even if they're not interested in stopping, this is something that we absolutely need to discuss with them at some stage, and hopefully repetitively over time. Because this can happen to anyone, not necessarily anyone, but pretty much any time. And that's important itself. Now, some of you may recall from your medical student days, there's a triad of symptoms. Some of you remember this and I had forgotten until I reminded myself, there is a triad of confusion, ataxia, and visual disturbance of some sort, usually nystagmus or ophthalmoplegia. So some ocular motor dysfunction there. Now, interestingly, only 10% of people who have got Wernicke-Korsakoff syndrome have this triad. So they see the percentages there. The majority are confused, but the rest are proportional. And to have all three is only 10%. So if you're waiting for the triad, you're going to miss a lot. And if we're looking at, as I said, I haven't seen much, but I think I'm missing a bit. I think we're all missing a bit, because the studies show that when there's post-mortem, about 80% are diagnosed post-mortem, and only 20% of people who've had this syndrome have actually been picked up while they've been alive. Now, the differentials of this is why it's difficult. These can look like intoxication or withdrawal or head injury, and they're all common things with alcohol. So the bigger message here is, rather than trying to pick it up, and certainly pick it up if you're noticing these symptoms, prevent it. And the prevention is so important. This is where pharmacotherapy comes in again. Korsakoff syndrome is a bit different, and it's a bit late. There's no effective treatment for Korsakoff syndrome once there. It's chronic, it's very disabling, and this is where you're, again, medical students teaching about confabulation, patients, compulsory lying. They're just making stuff up, not because they're trying to trick us, because they have no idea of what's going on, and they're filling in the gaps with great stories that feel are very believable, but dangerously so. So they've lost touch with that reality from a memory point of view. And unfortunately, there's no treatment. So really preventing this. So Wernicke is very treatable with thiamine, and really an inpatient thing. This is not a community thing you would do if you're picking up someone with Wernicke's. But the idea, what I can do in the community, is only prevent this. So why does this happen? Well, alcohol depletes thiamine. And we know that a lot of people drinking alcohol inadvertently will have poor nutrition, either because they're eating crap, because when you have a number of beers, pizzas and pies might be the better thing rather than healthier foods, or cost-wise, they're prioritizing alcohol, or in a circumstance where they can't access food. There's lots of social determinants of health that also coincide with alcohol use. So poor nutrition is common, and impaired intestinal absorption is common. Now, gastritis is very common, even if it's subclinical. And so thiamine is not a very well-absorbed vitamin to start with, and when you add these extra bits. So it's estimated a healthy subject absorbs probably 5% of an oral dose of thiamine. And an alcohol-dependent subject is about 1.5%. So it's 30% of what a healthy person would do. So they're really going to be likely to be thiamine deplete. And so the stats actually show probably about 80% of people who are alcohol-dependent have a thiamine deficiency if it was measured. So don't bother measuring it, just treat it. But thiamine depletion by itself doesn't cause Wernicke's. It's thiamine depletion plus brain metabolism that's increased. And so often when people are stopping drinking, they eat better, they're doing some stuff, and their glucose load and their brain having to work a bit more, either through the withdrawal or afterwards, is a higher risk situation. But this doesn't have to be just with withdrawal. But those two things together equal a brain injury, which is actually imageable. So part of their diagnostic workup at a hospital would be an MRI scan to have a look at those findings. And so, again, the symptoms for us, think about whether it is one of those differentials or whether it is possibly Wernicke's, and get someone assessed from that regard. But more importantly, as I've said, prevention. And so anyone who's got chronic alcohol dependence is at risk of this. So everyone who's drinking regularly should be offered pharmacotherapy, and that's thiamine. In the community, that's going to be oral thiamine. Because it's so poorly absorbed, it needs to be split dosing. And we often suggest, it comes in 100 milligram tablets, so 2 to 3 tablets, 2 to 3 times a day. It's very hard to overdose, and especially in the short term. You don't want to cause that. It's going to be renally excreted if it's if you're giving too much. But certainly trying to maximize that, because the absorption is so poor as a baseline. So making sure people have got a good dose around that is going to be really important itself. And if you're suspecting any of that complication stuff, then seek specialist advice. This is where they need parental, which is very hard to access in the community. It's very expensive or not available. Whereas the oral formulations are quite cheap. A packet of a bottle of 100 tablets, $15, $20, depending on where you are. So it's not very expensive for the value and the prevention you're getting around that. Chris, any idea of how long would you say, if you're advising someone to take this, they say, well, how long do I take it for? What do you advise?
So if once you, it takes about 4 weeks for your thiamine stores to become deplete. That's not really answering your question, but and so I guess it depends what their nutritional status is like. But if it's pre-detox, I actually go, and there's no great guidelines around this, but I go really high and say 200 milligrams 3 times a day, and partly because I expect patients will forget, and also because only the bioavailability of oral thiamine is very low. It's about 5%. And we know that our drinkers aren't absorbing things very well anyway. They're not eating very well. Their gut is all inflamed. So and it's a water soluble vitamin, so you can't have too much. So I generally have the high doses pre-detox and during detox, and then once a day, once a day or twice a day for a month post detox if they're no longer drinking. And I say, look, and it's sort of like a reward, I guess, for not drinking, is as long as you're not drinking again, you can stop taking your pills.
Yep. And if they're still drinking, someone is not into detox, they're just basically contemplating or pre-contemplating changing their alcohol, then certainly maintaining this alongside their alcohol, if they're able to, is what the advice would be from there, because the risk continues. It's not just you didn't treat it and it's sort of gone away. Yeah,
absolutely. Keep taking it.
All right. Okay. Any other questions that have popped up since we've last turned to the question?
Yes. To save me typing answers, Paul, this is great. Would you encourage patient taking oral magnesium, considering it's relevant to thiamine absorption?
Oh, I don't know about the thiamine absorption side of things. I do know thiamine is partly inhibited with calcium salts in terms of the medication, which are calcium salts. I'm not sure about magnesium. Don't know whether it helps or hinders. Do you know?
Yeah. So that's right. I mean, I don't generally recommend magnesium as well, but you are right. It is implicated in thiamine absorption, unless I've got a low magnesium reading, and magnesium is an easy blood test to do, and hypomagnesemia is very common with alcohol as well. So at the Gorman unit, we're often replacing magnesium IV. So yeah, I mean, if you're, I think if you're low in magnesium, that's a sign of pretty bad malnutrition, and I'll see a lot more of that in the Gorman unit, in the inpatient unit, than Paul would in GP land. But yeah, it's a good point. And if someone really isn't eating, then I do recommend a multivitamin, which generally has magnesium in to go alongside the thiamine. And that's another easy, cheap win.
And I would do a multivitamin. Yeah.
Multivitamin, exactly.
Anonymous
attendee has got another question. Could you give examples of loading dose and symptom-based method of diazepam regimen? So look, unless you're working in an inpatient department, I wouldn't do loading doses in the community. So really at St. Vincent's, we only would use a loading dose in somebody who has a prior history of proven alcohol withdrawal seizures or delirium tremens. And what we would do there is wait until their last drink was 6 hours ago, or their blood alcohol level is, or the breathalyzer is less than 0.015. And then we'd hit them with 20 milligrams of diazepam, wait an hour, give them another 20, wait an hour, give them another 20. 60 is usually enough. We can go up to 100 if on day one, if that's not enough to control their withdrawals. And then generally after that, we know that they're safe from a seizure perspective, and we put them on a symptom triggered CWA withdrawal scale for the next 4 days. But as I say, I really wouldn't do that in the community. Paul's got a really great method of symptom-based diazepam prescribing. Do you want to sort of tell people about the?
Yeah, I basically have a combination with Clean Slate of a fixed dosing as well as a sort of a symptom-based. So I do have a fixed dose, but then it's flexible because I've got a nurse available in a daily review. Then we use a short alcohol withdrawal scale, which is basically very much a patient report. So there's no blood pressure, there's no physiological measurements. It's very much how they're feeling and along a number of factors. They will score that, and if you know the SAWS, then if they're scoring below 7, I say withhold the dose because their symptoms are very mild, and diazepam is not going to necessarily have a role there. And if they're scoring, I think it's above 26 or something, mid-20s, then there's a spare dose that I prescribe that can actually be incorporated in that day, help bring those more severe symptoms back down to a sort of happy medium. So there is a fixed schedule, and there's some flexibility to either withhold or add extra doses, depending on how the patient's going. But I only do that because I've got nurse review every day, or if I was doing it myself, I could do the review myself every day, because it needs that flexibility and that assessment to actually allow the flexible dosing to occur. Otherwise, if that's not occurring, the fixed dosing keeps me safe, and I know it's actually happening. There's a reasonable dose happening regardless.
I'm just going to pop a link to that short alcohol withdrawal scale in the chat. And it's what we use as our detox diary at Clean Slate Clinic.
Yeah, and I just saw briefly there was a question on the multivitamins, and they often will have thiamine in them, but not enough. There won't be 100 milligrams. There'll be 10 milligrams or 12 milligrams. There's nowhere near enough. The multi have lots of small bits. So that's great for, no, actually probably not great for many people. But if you deplete on something, you need to address that directly. That's with a lot of vitamins. Look at the specific treatment of that deficiency. Let's move on to the third of our broad clinical scenarios where pharmacotherapy is involved with alcohol, and that's with cravings. And we alluded a little bit earlier about what these are. And I think, well, not I think, it's basically, as you said, it's more an urge or a desire if people don't relate to the word craving itself. But it's often an intrusive, a thought that comes in, and it's often hard to shake. It sort of just sits there. It's like a little bird chirping in your head. Have a drink, or have a pizza, or sit on the couch, or watch a game, or all of us have this. So this happens very regularly. And so it can happen any time as well. There's no particular time, but one of the things I encourage my patients to do is really start to reflect on when they have cravings, what's created that craving. And some will say, I don't know, they just happen. That means I'm not aware of why they happen, because often there will be some situation. So the big three people talk about are stress, particularly after work, stress with family as well, boredom, sitting there, I've got nothing else to do, so I may as well drink, and the boredom itself is the trigger. Loneliness, sort of related to boredom, but a bit different there. Various senses, I smell, I feel, I touch, I see something, and then it reminds me. So people driving see the bottle shop sign, and that reminds them what's going on there. Certain people trigger me to drink is often what's talked about there. Social situations like parties or weddings may be significant triggers for others. And that's so the events, as well as being in the social environment, there's often a cultural expectation of drinking. That's a strong undercurrent in Australia. And so that they're all potential, and I put to the common ones there. There'll be individual ones that are very unique as well. So for me, it's really helping patients explore this, because if they understand their cravings a bit better, it gives us a better chance of having some strategies around that, which actually are not pharmacotherapy, by the way. All right. So why do these happen? Neurotransmitters. I'll just throw that word up there. Something to do with the brain. Again, we don't know how it works. We know there are neurotransmitter adaptations, and people have measured this. But really, it's poorly understood why cravings occur, because there are certain patients that have really strong responses to some medications. We think, okay, that neurotransmitter is definitely involved, and others have zero. So there's obviously a multifactorial factor around the neurotransmitters. But certainly, it's just basically, it's a habit that maybe is creating some neurotransmitter adaptation, but there is a habit that's happening, and the brain, the body, the mind, something is finding that habit and being able to trigger it. Now, it happens to everyone. This is not unique. This is not, so we're talking about alcohol. Not everyone with alcohol necessarily has cravings all the time. Those with alcohol use disorder often invariably do. But all of us have had cravings for something in our lives, and sometimes quite regularly. Sometimes, so all of us may have an experience of what cravings feel like, but they are very unique. So I wouldn't portray how I feel a craving is on someone else. One nice technique to do for someone who's able to sit with a craving, which may be a skill they haven't developed yet, is to time it. How long does it last for? And with alcohol, the average time is about 25 minutes. So I tell patients this: if you can last 25 minutes, you're better than average in lasting through. And they may feel, patients come back to me and say, actually, mine's 18 minutes. It seems to settle down. Okay, so maybe a technique here is to do something for 18 minutes. Find a 20-minute activity that you live with the craving, and by the time you finish that, your craving's pretty much gone. It's one technique. Now, that, again, that's not pharmacotherapy. This is a psychobehavioral therapy. But with cravings, it's very much about psychobehavioral therapy with some pharmacotherapy support, which we'll get to very shortly. There's a little bit of research about those that are more likely to get stronger cravings, which goes alongside also some of the risk factors of developing a more severe alcohol use disorder as well. So those with more severe disorders often have more problematic cravings, probably go hand in hand, one feeding into the other. Now let's go on to pharmacotherapy, and again, reminding us this is a smaller component of the big picture, but there are two main ones we're going to talk about today. We're focusing on TGA-approved, evidence-based first-line treatments tonight. There are other treatments that either are not TGA approved or not first line or don't have a good evidence base. And I'll allude to those, but we won't talk about those initially because we want to make sure you guys are doing the best in terms of focusing on medications we know have the best chance of working for your patients. All right, these two, I'm going to show you a side-by-side comparison. So acamprosate and naltrexone are our two main players today, and there are different neurotransmitters they affect. In the bottom line, it doesn't really matter knowing which one it's working on because you're looking at the actual effect for the patient, not necessarily, these aren't measurable in our day-to-day stuff. The research shows the number needed to treat is slightly in favor of acamprosate to naltrexone, but I would say overall, and in bold, I put things that are very much equivalent, even though this isn't perfectly equivalent. The number needed to treat of 18, which is the worst of our two numbers here, is excellent compared to a lot of other medications we prescribe on a daily basis, which got numbers that treat of 60s, 70s, 100s. A lot of our medications actually have really much smaller benefit than when we actually look into it. So both these medications have got quite a high benefit, and this is for abstinence. So with these, you need to treat 1 in 11 or 1 in 18 to have an extra person be able to maintain abstinence by using these medications. If we're looking at patients reporting, both are about 80% of people on one or the other will report some benefit. They notice an effect and they feel like it's helping them. Now, that may not get them to actually stop drinking entirely, so there may not be abstinence. They may help them reduce drinking or help them support as part of the picture itself. So the two numbers there are sort of at odds, but they're measuring different things. One's about that helpful effect the patient's experiencing. One's a more objective effect of how they actually drunk itself. So both are quite good. They've got a good patient response. They've got an excellent number needed to treat. Contraindications, not a lot that we see commonly. So allergies rare as. Renal failure, we're talking about renal failure, not just renal impairment, but that can be an issue with acamprosate. And we're talking about severe liver failure. So one of the things that I've seen is GPs reluctant to prescribe these because patients have some liver dysfunction. And we're talking about patients here that should not have these medications or have them in a specialist advised way if their LFTs are more than 3 to 4 times the normal limit. So for most of the time that I'm seeing patients in the community, they've got liver dysfunction, but it's not above 4 times. If it's above 4 times, that suggests to me the metabolism is not going to be that great, and I need to get some advice about do I avoid that medication? Do I dose reduce? What do I do with this? And that's where I get some special advice for those patients. But in the community, most of my patients aren't in that situation. They'll have either some or no liver dysfunction. These medications work perfectly well. And if it can help reduce the alcohol and stop it, then actually will help their liver dysfunction improve as well, because the liver is quite resilient unless it develops some cirrhosis, which is then permanent. I'll keep moving.
Just to reassure people, they did a big review of naltrexone prescribing in people with cirrhosis, in people with compensated cirrhosis, and in people with decompensated cirrhosis. They did a huge prospective review in America, and they didn't find any drug-induced liver injury that they could pinpoint was due to naltrexone. So I think even the Australian Medicines Handbook is a little bit cautious still when it comes to naltrexone. So we don't have to worry too much.
Although I would, if someone's got cirrhosis, it's a handball to a specialist. This is
Yeah,
not
yeah.
someone I want to look after myself by myself. But certainly there is reassurance around naltrexone itself. Um, you would monitor liver function test. We do that. Naltrexone can cause the enzymes to rise, and if they're borderline, they might rise a bit further. So that has to be looked at as part of the review itself. Drug interactions, the main one to be very cautious around is with naltrexone and opioids. Someone's on opioid therapy, they can't have it. They'll go in precipitated withdrawal if you give them naltrexone. Someone who's on naltrexone and needs an opioid, advising their team. So pre-surgery, an anaesthetist or an emergency from a burn or something they need, say morphine or something else like that, advising the team that they're on naltrexone. Then they can give an alternate forms of analgesia, a femoral block for a broken leg, for example, rather than opioids. If someone's got planned surgery, stopping naltrexone 2 or 3 days prior to that will be flushed out so they can have their normal analgesia prior to that, and they can reintroduce it after that. So that's the only real major drug interaction, really. The rest, they're otherwise pretty clean, and most patients that I see are concerned about their antidepressants. There's no issues with that at all. And again, if we can reduce the alcohol, it'll help. It's an antidepressant in itself, stopping alcohol. The next line here, dosing is very different. Once a day versus 6 tablets a day in 3 split doses. So that often is a deal breaker for some, and for some actually they quite like the fact that they've got a routine. And I've got some patients that take their ADHD medication 3 times a day and say, oh, 2 more tablets ain't gonna make a difference. It's all good. And others say, I couldn't possibly remember 3 times a day. I'll stick to the once a day one. So often this is the biggest factor, patients choosing one over the other, but it's not the only factor as we're alluding to. They're both PBS, they're both streamlined authority, they're both very easy to prescribe these days. A couple of clicks and it's through as an e-script on the patient's phone immediately. And so they're available with a month plus a repeat. And some patients want 6 months worth. I think while that's very convenient, someone with recovering from an alcohol dependence, really a 2 monthly review as a minimum, I think is fair. Because there's a lot of other things, that broader health thing, not just the medication part, but the broader health, that recovery needs to be looked at, and we need to support that as well as generalists. Both are very similar in terms of onset. When we start usually after they've stopped, not at the start of withdrawal, because again, you've got a new medication, you don't want their medication to be confused with withdrawal symptoms. But once they've got through the worst, that's a good time to start. So usually towards the end of that first week. Sometimes it can be delayed a few days after they've stopped altogether, but try and at that stage, that's the time to start. So this is for craving reduction. The other area here is how long you treat them for. I often say, look, a few months to 6 months gives you a chance to have this tool to support you while you're learning other stuff, learning to live without alcohol, learning to navigate the shouts at the pub, the people offering you a toast at the wedding, navigating all those situations, learning it with some extra support so that when you eventually stop the medication, you've developed those strategies. But it can be used indefinitely for some people. So there's no time frame that they have to stop necessarily. Just use it for as long as they feel it's helpful. Now, naltrexone can be used. Acamprosate doesn't really have any role here, but can be used intermittently for certain scenarios. So for some patients, I've had a few patients that use it just in summer during the festive season, and then the rest of the year they don't use it at all. That probably would work acamprosate as well. Some use it just on a weekend. So naltrexone just Friday, Saturday, Sunday, or whatever the days would be, help reduce the cravings on those days, and they find they can navigate it without itself. Camprel or acamprosate, I wouldn't do that. It's more of a regular medication, but naltrexone can be used sort of just more PRN for some. But for those that have gone through withdrawal, I strongly encourage them to keep it as a continuous medication for at least a few months before they start experimenting of seeing how they go without it. Because that's the most vulnerable time, those first few months of, basically for any behavior change to maintain it from there. And they're both well tolerated. Now, they've got different side effect profiles. Camprosate generally is mainly GIT upset, usually short-lived. And we know naltrexone there's a few other ones. None of them are dangerous, more bothersome, and again, usually short-lived. So for mostly, it's very reassuring, but you've got to be mindful that they may have some symptoms. If they're getting something like some nausea or some headache, they can be managed, and also reassuring them it's unlikely to continue.
Well, we just got a question about cost.
Yes. So they're both on the PBS. So if they're a a healthcare card holder, concession card holder, they're eligible for a that subsidy. There's a $7 mark, depending on when you listen to this recording, what the PBS co-payment will be. And for the average punter, provided they got a Medicare, they're eligible for PBS, then it's about the $30 mark per month. So the same as the other medication, and usually much cheaper than the alcohol they're already being afforded.
Yeah.
The other thing that's mentioned often, can I use the two together? There's actually evidence that the two together work better. The number needed to treat actually is lower. Again, more medication. The two work synergistically. They work through different chemical pathways, so that there is that benefit if someone needs further help. But I wouldn't start off with two at one time. Build upon one versus the other if needed.
A couple of questions about clonidine in alcohol dependence for cravings or withdrawal. And one about Seroquel or quetiapine for sleep during detox.
I will get there. I'll get there. I'll cover
Okay.
disulfiram first. Yes. So this is the other one that's TGA approved. I won't say, I'll say evidence-based, but the evidence is pretty light. Only a few really, good, reasonable studies showed some strong benefit. The interesting part was the open label studies showed good benefit. The blinded studies showed no benefit over placebo. So it looks like if you know you're taking it and you can see it, you got more motivation. If you're not sure, it's probably not working as well. So it's really the belief that it's working. It's probably the bigger thing here. So there are some downsides. So this one blocks the alcohol pathway, gives you a toxic metabolite that you can't metabolize further because it's blocked. It makes you feel crap. Not everyone gets this response, and some get this response very sensitively. So from aftershave, from mouthwash, for things that when they're not ingesting alcohol but still getting into the system, they can still have this. So it can be a bit hit and miss. It doesn't affect cravings at all. So it's not really craving reduction at all, but it is something that is more of a aversive therapy. The number needed to treat has never been defined. The studies just aren't, there's not enough studies that have looked at this properly, and it's not on the PBS, and at the moment, not really accessible. It's not, at the moment in Australia, it's not, getting it's very difficult. Sometimes there'll be a small supply through a pharmacy, but it's not regular enough at the moment. So something that we would use I wouldn't say rarely, very uncommonly. It's still used occasionally for very motivated patients in a very particular sort of situation. But most of the time, people stop the medication versus stopping the alcohol. And they can stop the medication, and they can have that big boost on the weekend, which is what they're craving, and therefore it's not really that helpful. Now, we're not going to cover off-label things like baclofen or topiramate. There are some other symptomatic things that we can look at. Now, in terms of quetiapine, I personally steer clear of that. That's with alcohol. And clonidine, not for how much, actually the evidence with alcohol is it doesn't work. With evidence for other disorders, maybe, but alcohol, certainly there's some reasonable evidence that actually it's not worth trying, which is interesting. So they're probably in a controlled environment as a trial worthy of having a look with selected patients. It's not something that I would do routinely across the board or think about on a regular basis. I'll just focus on these three other conditions. They've all got pharmacotherapy. So we're talking about alcohol, opioids, benzos, and tobacco use disorder all have a pharmacotherapy component in treatment. Now, again, we've only got an hour today and we're already using up most of that time. So I'm going to go briefly about these. Opioid use disorder, there is strong, super great evidence of buprenorphine and methadone being life-saving, being community-saving, and excellent treatment. Not as a withdrawal treatment, but as a maintenance treatment. Now, each state and territory have different regulations. We have got no time to go through all that complexity. So my basic message here is look up your local guidelines and see what you can and can't do. But some of the states are a bit more liberal, especially with buprenorphine prescribing, and some have still got a lot of regulations around that. So that'll vary a bit. But this is the evidence base for around opioid use disorder. Much stronger evidence than just trying to taper off. And if someone's unable to taper, really struggling and getting stuck all the time, reconsider the idea of opioid use disorder being part of that barrier. Benzo use disorder is different again. We use benzos for benzos. In this case, it's a tapering, but it's a very slow taper. And the main philosophy here is to switch over to a long-acting one. So if they're not already on diazepam, transfer across to an equivalent dose of diazepam, stabilize that dose, and then very gradually you do a gradual taper. And that can take months, even a couple of years, sometimes for people who are on very high doses to taper off. The benzo withdrawal is very prolonged and it takes time to gradually things, and this is with the patient. Forcing this on patients will turn people away from medical services, actually can cause more harm. So it's really about that motivational interviewing approach to get them on board. Gradually, this is a slow burn, but it's important. It's really quite rewarding seeing people come back to you saying, I think more clearly now. I didn't realize how clouded my thinking was last year, but now I actually think much better. Thanks, doc. But last year, they're complaining all the way. This is terrible, doc. I know I want to do it, but it feels terrible. So it's reassuring and really very supportive. Gradual taper is the important part. And again, tobacco use disorder. I think most of our audience will be very familiar with tried and true and the evidence base around this. So Champix or varicycline is probably our best pharmacotherapy that we've got available from an evidence base. Bupropion or Zyban has a place as well. They're the two oral medications. And then we've got nicotine replacement therapy in its various formats. These can be combined, and PBS has got its own rules around what can be done and what timing and how much in 12 months, and look those up themselves. So this will vary a bit. There is some evidence around inhaled, like vaped or inhalers NRT, but we won't talk about vaping today because, again, it's a whole other topic itself. Now, I'll bring up alcohol use disorder particularly because I want to give you some reassurance that there's some good evidence that combining habit change, like quitting smoking and alcohol at the same time, is more likely to have success than staggering. So initially, my initial thoughts was, let's do one thing at a time. Don't overcomplicate things. Get your alcohol sorted. Then we'll cover this. Then we'll cover that. And the evidence shows if you put a few habit changes, because the patient's already in habit changing mindset, they may well be able to combine them successfully, provided they want to. So again, they need to be gone from contemplation into that action phase. But if you can help them with some reassurance that you can do this together, the treatments here rarely coincide in terms of causing problems, and it can actually be synergistically beneficial, then please do so, particularly with smoking. If we can get people who are quitting something else plus smoking, we're doing a huge service to their health and our community. My final substance slides here are cannabis and stimulants, and they don't really apply today. We're talking about evidence-based first-line pharmacotherapy, and unfortunately for these two classes, there is no strong evidence base for pharmacotherapy. There's lots of current research, particularly around cannabis disorder, that may change, and this may be a webinar that becomes extinct in terms of this last part here. We might have new information. We'll certainly provide that for you if it comes along. But at the moment, there's no pharmacotherapy that's been proven to make a big difference around this itself. And there's been a number of studies looking at both classes. This is where some symptomatic management may be appropriate. Again, not really evidence to show people that makes a big difference. It makes it a bit easier. With cannabis, it can be prolonged, so you've got to be very cautious of how long you're prescribing things for. So particularly with and olanzapine or diazepam, I really focus on a very short sort of a rescuing type of treatment, not as until your symptoms have gone away, because symptoms won't go away for months or weeks potentially. And again, very cautious around this. With an agreement and very clear tapering plan from the outset, not a set and forget, because then you end up with two dependencies quite quickly. Within a few weeks, you'll get start to develop a diazepam dependence. So for those who are interested in cannabis and stimulants, there's not much to add at this stage. So I'll move on and remind us of my initial framing. Medications, yeah, they're important, but they're only a part of the things. And if we're focusing on just script and nothing else, probably not going to do as much. If you forget the medication, do the rest of it, you probably got a lot more benefit. There's a lot more evidence and support and resources around the physical, psychological, and social approaches, which we might cover in another webinar. Now, I did promise a resource. So these treatment guidelines are excellent, and this is where a lot of the source material for today came from, apart from our own experience. So please utilize these guidelines. They're really a handbook, and they're very helpful. You can download the PDF. There's an online version, all very clickable and very user-friendly as well. So, Chris, any further questions or anything else here? We've gone a bit over an hour, but we've got a bit more time just to wrap up for those that want to stay and just listen to a few more things.
Some lovely comments, and thanking you for your wisdom as always, Paul. Is there any evidence for Vyvanse? I assume that means for stimulant use disorder and not ADHD.
Yes, there's good evidence about ADHD. No, for, say, amphetamine use disorder, there are some studies looking at that. They haven't really shown enough promise for it to become something that's what we'd consider something we'd promote at the stage. It may be watch this space. Certainly the longer acting medications tend to be useful as a replacement therapy down the track, but the evidence isn't strong enough as far as I understand with Vyvanse to date.
Yeah, and Vyvanse is Lisdex, isn't it?
Yep.
And certainly at St. Vincent's, we did do a pilot study on using Lisdex for crystal methamphetamine withdrawal. And it wasn't a big powered study. I think it was 20, maybe 30 clients. But the people who use Lisdex for withdrawals did experience like they had a better experience of detox. They had less withdrawal symptoms using the Lisdex. You can be prescribed Lisdex for, I think it's Lisdex, it might be dexamphetamine itself for again, maintenance of stimulant use disorder. But I mean, we have a stimulant treatment program at St. Vincent's, and I think we've only got one person in that specialist center who is using Lisdex or Dex for maintenance. So again, it's very much in the specialist realm.
Right, absolutely, it's off label and not on the PBS at all for these reasons. So it becomes even if you thought about it,
yeah, that's it.
Great. Any other questions?
No, let me see if there's I went a bit rogue and answered a lot of them on my own. You might want to go through and check that I've said the right thing. But yeah, no, I think we've answered everything that that came up in oh, what's this? We've got some new ones. Thank you, very informative from Bronwyn. Anonymous attendee did enjoy it, so that's good. Thank you, Anonymous, as did Tracy. So I think we've answered them all. If people do have questions that they've not asked or think about later, then please email us on at services@cleanslateclinic.com, or if anyone can has an idea of something they'd like Paul and me or one of our other great clinicians to talk about, again, drop us a line. We're always looking for new topics to discuss in the world of addiction medicine. So yeah, feel free to email us at any time, and if you want help with your own patients, we're always happy to do that as well, of course. Great. Well, thanks.
The question, the quetiapine, the question was, is it dangerous to use a typical antipsychotic such as quetiapine for sleep in patients who stop drinking while on diazepam for withdrawal? And yeah, just as Chris said, just a caution around adding more pharmacotherapy to what's already a complicated physiological readaptation with that alcohol coming in. So you've got the complication of the withdrawal symptoms. You've got diazepam, which is controllable and known, and then you've got other medications coming and going, which can either mimic or complicate things from there. I'd just be very cautious around that. For me, the sleep, diazepam really, although he's said to dating, it's well overprescribed for sleep, and it really isn't. There's no real, it shouldn't be used for sleep, but unfortunately it is.
No, I really would warn. I would advise against it. We used quite a bit of Seroquel when I worked at William Booth House in the residential rehab, and for sleep, because it was such a common issue, and a lot of patients would be very groggy in the morning, which was expected, but a lot of them would slur their words. They call it the slurry drug. And if you're taking someone through a withdrawal and they're turning up slurring, and I don't know, but that's just one of quite a few side effects that Seroquel can cause, and then if you putting that in a cocktail with diazepam, it can just be tricky to pick things out. And yeah, I don't use it, to be honest.
Well, that looks like we've wrapped up everything, Chris.
Yeah, thank you so much, Paul. I can go and have my dinner. I know you've had yours. But yeah, thanks again, Paul. That was brilliant. I always learn something when I listen to you talk, and I really appreciate it.
Experience as well.
Thanks
a lot.
Thank
you, everyone.
Thanks very much. Thanks.